Hello everyone, welcome to the third episode of season 2 ICPA clinical series. As you all know, season 1 had each episode one clinical challenge, and season 2 has a different topic in every episode. And this is the third episode, and the theme of third episode is clinical challenges and expert solutions. And for this episode, we have taken a very popular topic, that is aesthetic and cosmetic dentistry, and that too from a person who has been practicing aesthetic and cosmetic dentistry for the last 40 years in Mumbai. That is Dr. Pankaj Maheshwari. Welcome, sir. And it's my privilege to have him on the show. It's also my privilege to have another aesthetic and cosmetic dentist, Dr. Usha Dadlani, an award winning aesthetic dentist from Navi Mumbai, very active in not only clinical practice but also in publications and presentations. Let me introduce Dr. Usha to you. Dr. Usha completed her BDS from YMT Dental College, Navi Mumbai, and since then she has been practicing in Kopar Kharne, Navi Mumbai, as an aesthetic and restorative dentist. She is an accredited member of Indian Academy of Aesthetic and Cosmetic Dentistry, or IAACD. She is currently the assistant editor for aesthetic dentistry in Dental Tribune South Asia, the world's dental newspaper. Dr. Usha was the winner of FAMDent Award for Aesthetic Dentistry in 2022, and before that in 2019. She is also the winner of Aesthetic Dentistry category dentist in Indian Dental Divas in 2023. Dr. Usha has co-authored a chapter in the book Clinical Fixed Prosthodontics and is the author of numerous articles in national and international journals. And in 2019, she received her ISOI fellowship. So I welcome Usha, and I request Usha to introduce Dr. Pankaj Maheshwari and get the ball rolling.
Thank you so much, sir. Thank you for this wonderful introduction. We have Dr. Pankaj Maheshwari with us today. He passed his BDS from Nair Hospital and Dental College in 1984, completed postgraduate certificate course in aesthetic and cosmetic dentistry from NCOD, affiliated with Sunny University at the Buffalo, New York, USA. He is the past president of the prestigious Indian Academy of Aesthetic and Cosmetic Dentistry. He has participated in and conducted numerous national and international level conferences and seminars as a keynote speaker. He runs a successful aesthetic and cosmetic dentistry practice for more than 40 years in Andheri West, Mumbai. He also conducts a very popular hands on course called Smile Design Week for dentists who are aspiring to build aesthetic dentistry and smile design practice. It is indeed an honor to have you, Dr. Pankaj Maheshwari, sir, amongst us today. This stage is all yours now.
Thank you, Dr. Usha. Thank you, Dr. Rajiv. So, good evening,
You
friends.
can
It's
start.
nice to yeah. Good evening, friends. It's nice to see all of you joining this program at 9:30 after finishing your practice. So, without wasting much time, let us begin. I'm thankful to ICPA for conducting this wonderful program so that we can be in touch and updated with our knowledge of dentistry on a continuous basis. The topic for today: three essentials of smile design. Smile design is a big topic, cannot be covered and compacted in a few minutes. But it will be my endeavor to throw light on the most important points which we must keep in mind whenever we are getting into the smile design work. So, when we talk about composites, what comes to the mind? That there are some problems. We should call them issues and concerns. And all these issues which we encounter in our practice, day to day practice, are solvable. Once you learn the proper fundamentals and learn to understand how does it whole system work and what steps we should take, then all these issues no longer remain in your practice. The first and foremost, the most important essential of any aesthetic dentistry will be the bonding. Bonding, but I use so many of them, and it's become a big jungle of adhesives today. So many products to choose. Which one I should buy? So one gets kind of a confused, and if you're relying only on the salespeople of different companies, each of them claiming that their product is the best, and not only the best, but they saying that this is the only product which can work. One tends to get more and more confused. So I would like to just clear this confusion, a small steps, by just throwing you a light on the whole bonding systems. So essentially, there are two techniques which have been used. Now, all of you must have read this slide that what happens in the total etch is when you apply the etching gel on the dentine, the entire dentine, the collagen fiber up to the up to the level of 5 micron gets the collagen gets etched, removed, and the fibers, the tubules gets opened up now. After the application of bonding agent, the tubules get blocked, and what you get is a hybrid layer. Now this hybrid layer is the source of your strength of bonding. Inability to create a perfect hybrid layer is the cause of success. So in a nutshell, I would like to just say, please follow the protocol of instruction which is given with each bonding agent, which are different from product to product. Companies have spent millions of dollars to create the product, to test the product, and give us a protocol. But where do I get this protocol? In a small white paper, instruction for use, which comes along with the product. Please don't throw it away. Have a look at it and then follow the system to the T. Self-etch was basically developed to take care of the sensitivity issue. The major difference between this technique and the total etch is that there is a self-etching primer which does not remove the layer, and it will the smear plug and the smear layer. It gets incorporated and form a thin hybrid layer. Now you also get the resin impregnated smear plug to complete the bonding. So follow the instructions, do step by step, and of course one can use the selective etch technique also. So rather than going from a different system, let me give you an illustration. Now let me tell you in the beginning only, I'm not promoting any particular product, but this is just for an illustration. You are most welcome and encouraged from my end to please look at different companies, different products. So let's say the 3M SP. They have a one system called Scotch bonding multipurpose, in which there is a primer and adhesive, two separate bottles. Now this is from fourth generation of bonding agent. Over a period of time, they merged together the primer and adhesive and created a single bottle total etch system in which you etch and apply. Over a period of time, now what you have is at per easy one. This is the sixth and seventh generation of bonding agent which is available. There is total self-etch. But then came a revolution for bonding, and that was called universal category of bonding agent. What is universal category? That it can be used for total etch, self-etch, and also selective etch. It's far more better and far more predictable to use universal. So, with the essential part of the dentistry which we do day in and day out, these are the cases which we should be able to do it properly. And it is restorations with the limitations of clinical indications as class 1s and class 2s, where you can put these restorations and they will keep on going and going and going. Cervical area, which is either because of erosion or because of the decay, can also be restored to the perfection. And when the patient tells you after you finish your work, doctor, where is your filling? That I find is the most important, is the heartening compliment, that you are unable to detect the restoration margin and the colors match. This is all possible. Nature is full of colors. You look around and you see shades, you see different colors, and you see reflection. But why you see what you see? That is the question in terms of colors. And when it comes to the teeth, we normally take the shade guide and try to match it, but does not match all the time, because tooth is not a tab on the shade guide. It's nothing but rights of colors. Keep that in mind and then start selecting the material. Of course, you need to learn more detail about it by understanding the color theory. Also, one must also understand the structure of the tooth which you're going to restore. Now, when we look at the tooth, now I'm not here to show you the histopathology, which you all are aware of. I would like to please give this attention to optical property of this tooth. Now, because the thickness of the enamel is different from cervical to the middle and at the incisal edge. So and in the center is the pulp, which is, and sandwiched between the pulp and the enamel is the dentine. So what you see. Now let's look at for a moment what will happen if the light passes from the cervical area, from the buccal aspect, goes through the enamel, dentine, pulp, dentine, enamel, and then comes back. Because remember, whatever you see the color is because of the reflection of the light which is coming back to you. If the light is absorbed or is deflected, you don't see that particular color. Now, once we say the light is passing through the middle portion of the tooth, it will only pass through the enamel, dentine, enamel, and come back. At the tip, it is only the enamel. So what you have got? Different optical properties of the tooth are reflected. And the biggest challenge what we face in our aesthetic dentistry is to replicate the colors of the tooth. Now, it is not only the shade which we have to match, it is also the optical property. Because if you don't match it, it will look fake. Now, here the nanotechnology made a huge impact to us. Around 20 years back, when the products started coming with the pure nanofill, and today most of the products are having nanocomposites. So why it happens that in a hybrid and microfill, you are able to get a blurry image, but in nanocomposite, it is almost transparent. It is because the nanoparticles are smaller than the wavelength of the light. So light, when it passes through, instead of hitting it and getting deflected, it can go from the side, giving rise to almost transparent composites. It is possible today. Now, let me again give you an example. So there are some composites which can be translucent. Where I will use them? At the incisal edges. Because as we just saw in the earlier slide, enamel is transparent at the edge. Now, there are some enamel shades which are more transparent than the body shade, but less than the translucent. One should use them at the replacing of the enamel. Body shades, where it will be translucency is closer to the enamel, and there are ideal materials to use for the single shade restoration where the cavity is not big deep. So we call it them body shades of composites. But certain time you need to block the underlying color. Remember the class 3s, we remove the decay, and then at the end of it, you see that there is a small brown spot or a black spot, but it is not active decay there. So if I put directly my composite there, it is going to give that patchy black appearance. Now, if I want to block it, then what I can use are the dentine shades or opaque composites. What they do, they will block the light. So whatever is the light, when it passes through that area, everything is blocked. They come in different shades as well. The product is available as Z350XT from 3M. Okay, enough of lecture. How do I use it? Let's say you get a case like class 3 here. There is a decay here, and being very conservative approach, you remove the decay. Now you are faced with the challenge that there is a cavity which has gone through and through, and you need to also take care of the margins of the preparation. So following the step-by-step procedure, one can restore this tooth using the aesthetic composites material which are available. I'm sure all of us must have gone through these cases in our practice, adult or a junior or the child. Earlier, we used to just repair this and take it up during using a mylar strip, but we found out that it is a more time-consuming method and you never get perfection. So using the silicone indexes really helps you into getting the perfect blending of the composite layer by layer. We first block the light by using an opaque composite, and then applying layer by layer, one can go about it. Now, this is an art part of the dentistry. One can learn it in the aesthetic workshops so that you get a hands-on experience of doing the same. It is very satisfying that once you have restored the complete tooth and it is blending and the patient is telling you, where is my filling? One can apply same principles and similar material when you are using this for closure of the diastema cases. Now, diastema closure is one of the most common phenomena which occurs in our practice. I would say this is the first aesthetic procedure one can do it confidently and successfully. And there are some rules over here that up to 2 millimeter of the space, it is very good. After that, you need to be careful and watch it out. But while building the diastema, not only the composite should be matching the color of the tooth, but also we must create the anatomy. So it's like primary, secondary, and tertiary. So all these, the materials which you have applied, finally they need to be blended, and then we must create those grooves, the depressions, the roughness, the elevation. This is what gives life to this restoration. Why? Because on a smooth shining surface, when the light will hit, it will entirely come back in a 90 degree. But when there is a, the anatomy is different, it's not in one plane, the light gets reflected and also get deflected. Now that deflection gives a natural appearance to the tooth. And one can follow it up for handling it for more and more challenging cases of diastema closure with the laminate as well. A child was for playing and just fell down. Now, the parents just brought the child back from the school. He was crying inconsolably and he was worried. After taking all the proper history and examination, fortunately, there was no, the tooth was still in the socket. It was not luxated out. There was no, fortunately, bleeding of the gingiva. Now, this was a challenge. Now, instead of doing a massive work here, spending time with this child and working diligently and creating these restorations which mimic the tooth brings smile to the child. And for me, this is the biggest reward I get than making any kind of a money. The smiling face of a child. So, couple of years now, I have started following another layering technique. Minimal, I call it minimalistic anatomical layering, where you take a very small increment of composites and layer by layer. So let me show you this small video. It's a class 4 fracture. Silicon index was built, etching bonding has been done. The first layer of composite was applied, which was clear translucent composite. Since the defect is so small and there have to be multiple layers, we need to work very slowly. The excess is removed right now to have extremely thin amount of material. Something has fallen on the adjacent area, which is removed with the blade. Now, the opaque composite is used to block the underlying light. Again, a very thin amount of material is required and excess is trimmed out from the incisal edge upward. Now the body shade is applied as a second layer. We normally see the margins getting exposed. So a small band of body shade of composite at the margin is applied. Now the enamel shade. It is also covered at the corner. Little bit more enamel is required. All this while we are doing it, it is step by step. And after every layer, we are curing it. But because to consume less time, we have blended it. Now it's a translucent layer. This is blended. And I personally prefer to blend it with the brush using only 4th generation bonding agent resin. Only 4th generation resin bonding. The third part of aesthetic dentistry, which we call it porcelain laminate veneer. Now there are 24 principles, parameter one has to keep in mind. So each case, when you get looking at the smile design, it is not you don't start thinking whether I'm going to do the composite or laminate or porcelain. You have to think first, what is the case? So taking the pictures, looking at the patient, talking to the patient, going through this checklist, and then finding it out very, very carefully how I will proceed with this case and which material I will use. Now, the age plays a major part on the shape of the tooth. Sex, we all know, feminine and the masculine teeth, which also gives teeth also gives a little bit of personality, soft or vigorous. Now remember, all these minor points is what ultimately make your restoration, make your veneers natural. One of the most important factor which I find I must share with you is the embrasures, incisal embrasures. Normally, you leave it to the lab, they're going to give you the square teeth, and then it looks fake. Please spend time in creating these embrasures. The incisal length for maxillary teeth and the mandibular teeth. We all know, as the age advances, the smile line keeps on going up. The display changes. In the younger age, it is more of the lower upper teeth which are visible. As the age advances, the lower teeth are more visible. So earlier we used to take the teeth and then rely on a judgment for preparing the tooth. Not anymore. The best way to go about today is aesthetic pre-recontouring APR technique, in which you identify the area which is out of the arch by first making those silicon indexes on the final restoration, which on the final wax up, and then adjusting these. And after they are adjusted and following everybody, all of them are following an arch, filling the spaces with these APT. These are the composite materials which you will fill it up. Now, this is an basically a very broad view of what the final restoration will look like, and then you do your preparation through these composites. This is called AMP. After the preparation is done, we must take the stump shade, because whatever is the shade of the tooth which you intend, which was in the beginning, and what you intend to do, there is a gap. So the laboratory must know what is the stump shade, and this is stump shade is best of the picture. The photography are essential part of aesthetic dentistry. One must take a nice pictures by either using a DSLR, and of course the mobile photography are also available today, which gives you a fairly good idea. One must make a perfect rubber base impression. Now, when you are making the impression, what one must look at it? Number one, of course, is the margins. But more than the margin, what satisfying me is the fin, is a thin amount of rubber based light body which has gone into the sulcus. How this happens? Because you have retracted the gingiva sufficiently. So you get this moment, this fin is there and there is no tear of the rubber base impression, then only you send it to the lab. Never ever leave the patient without provisional. Provisionals can be fabricated on chairside. After you get the laminates in the mouth from the lab, please spend some time into fitting these laminates first under dry condition, the trying condition which we call. Each laminate should be tested and checked for all the aspect fit one by one. After which, all of them should be put together using KY jelly or any form of lubricant. The cementation protocol of laminate is very stringent. We always say that whatever time it takes to prepare the tooth for laminate, it will take minimum double or three times for doing cementation, because it has to be accurate and perfect. Follow all these protocol and cement these laminates. So for clinical cases like this, where the teeth are on different plane, it is so satisfying when you see them post-op. And for this patient with spaces in between, it is a life changer for him. You also do laminates for different cases, for reversal of the arch, the inverse arch. Or these patients, as a part of full mouth rehab, you can put some laminates here, these three laminates, and the rest of them are crowns. So you're merging with these laminates and the crown and bridge together to give that perfect smile to the patient. All right. Now the next question which I am asked most of the time is, sir, it is all fine. You're sitting in Lokhandwala complex, Andheri, in Mumbai, where you're getting lots of patients like this. But how do I enhance my practice? How do I develop my aesthetic practice? I'll just give you 4 tips. These are the patient concerns, right? Where are these patients? How to get them, how to convince them, and how to charge. These patients are there in your practice. Have you heard of John Perrott formula, 80-20 formula? It says 20% of the revenue of any business, in our case, our practice, comes from, sorry, 80% of the revenue comes from 20% of the patient. These are the patients who have gone through your higher end treatment, who went for root canal and ceramic crown rather than extraction or removal denture. How to get them? It's ultimately your work. And of course, you can show them your own work in the form of pictures. And if you find any issues, spend time, 5 to 10 minutes, and tell them this is the issue which can be addressed. Convincing them only comes from your own self confidence. Your own confidence that, okay, I can do this work, I have done this work, I have attended the workshops, I have worked on the models, I have done small cases, maybe a small one single laminate, or maybe just done a perfect class 4 or diastema closer. Your own pictures is the most convincing way to tell them that this is possible. Now, charges are the total, we call it as a combination of multiple factors. Number one comes your overhead, the rent and electricity and whatever you're putting it up, including the bank EMI and your salary to the staff and materials and everything. The second comes up is your upgrade cost. Now, upgrade cost does not mean only the clinic enhancement. It does not make the clinic is absolutely great. It is the most important resource in any dental practice is the dentist. And if you're owning the practice, if you're running your own clinic, then you are the most important person who should be upgrading the skill on a regular basis. So just talking to the person, and I think if you speak to a couple of your patients or friends, they will tell you that any good company, especially the MNCs, spend at least 10% of the time each person has to log in and learning. Now, even if we take that number, out of 300 days we work, we should ideally spending 30 days. How much time we spend? And there lies the answer to this question. So the solution is very simple. Attend the program, learn yourself, upgrade your skill, never be afraid, always think positively, and then enhance your practice. As mentioned earlier, these last 20 years, I've started sharing my experiences in the form of workshops. So there are 3 modules, biomimetic and this porcelain laminate apart from the essential. You can do only single module or all. We do 50%. The 50% of the time spent is on learning the theory part and 50% is spent on the hands-on. The lectures are online to save the time, and hands-on are in Mumbai. Either one can attend. Those who cannot attend, we have also for last 2 years, we are very successfully having the system of online from your clinic. We'll discuss about that questions if there is anyone later. Currently, there is an early bird offer which is happening, which is expiring on this Monday. So those of you who would like to avail of this and enroll for this can definitely go for it. Okay, now this is the QR code. Those of you who are interested in the brochure of this program, please scan this and you will have the brochure on your mobile, which you can go through it. With this, I end my presentation. We'll glad to see you soon and somewhere in aesthetic and help and wishing you all the best for aesthetic dentistry. So I finish my presentation now.
Thank you, sir. It was a wonderful presentation, and you covered all the key essentials of smile design. And we are really in awe of your clinical skills. And it was a great lecture. And Although I don't do myself aesthetic and restorative dentistry, but it was very, very inspiring for me as well. And you finished well in time. It is exactly, you had told me that you finish in 30 minutes and you finished in exactly 10 by 10:05. So we'll take up the questions that have been sent by the registered participants first. Once we finish the questions, then we'll take up the ones that are sent by our live audience.
Sure.
So, Dr. Usha, can you start with the questioning session?
Sure. Yes, sir. So one question is, how do composite veneers retain without preparing the tooth? And what would be the best finishing and polishing kit for the direct composite veneers?
Okay. So basically, once you put up the composites, when we're talking about how it will retain without preparing the tooth, the bonding works on the enamel. And when you etch the enamel, it can be properly bonded. The restoration will retain. But here is a small caution of advice. It has been found that once you roughen the enamel, the fluoride rich layer of the topmost layer of enamel, once you remove that, the bonding improves. So my advice to you, all of you, would be don't have to prepare if you're supposing it does not require preparation and to remove for structural depth. At least roughen the enamel to remove the fluoride rich layer, bond it, and then the restoration will be fine. Second part of the question was polishing kit. Okay, there are many polishing kit which are available. I would say I would categorize them into different parts. So the categories of the polishing kit earlier we used to use stones. Now these stones, what used to do was basically roughen the whole thing. Now that was okay for hybrid composite, not for nanofill. Nanofill composite is much more smaller. So one must use the aluminum oxide. So aluminum oxide will be available in the form of disc. I think a lot of companies have got it, and the another would be the spiral. So the 3M, for example, has got Softlex polishing disc, and it has also got Softlex spiral. The spirals are nothing but the aluminum oxide which is inside the rubber-based material. So it is becomes very soft, and most importantly, it can be contoured in any way. So it becomes very useful, especially for posterior as well as to maintain those grooves and anatomy of the anterior tooth.
One of the things that I like personally in the Softlex is they can be used reverse. So
You can use it, yes.
really help in the palatal finishing and polishing. That
So
system in particular is really very good. So that's my
yeah,
favorite too.
yes.
So moving over to the second question, how can a smile be aesthetically designed when the anterior teeth are missing, taking into account the proportion and aesthetics?
So whenever you're doing any smile design case, remember the first thing, never jump on telling the patient what you feel can be done. Take time, take models, take photographs, analyze the case, and always prepare a mock-up. Always prepare a mock-up. Once you start preparing a mock-up, either by yourself or by the lab, then you come to know what is exactly the width of the tooth, how you're going to be designing it, whether you need to put an implant. If you're going to put an implant, what would be the crown width, and vis-a-vis the adjacent space available. Whether you need to also, add composite or other material, ceramic on the adjacent teeth, because the proportion has to be there, because you can't have suddenly one flat, very fat tooth or one small narrow tooth in the middle. It has to be blending with the adjacent tooth.
Very well said, sir. Also, the digital mock-ups nowadays help a lot,
Yeah.
right?
So if you're doing the digital mockup, remember that you must give a test drive to the patient. Whatever you prepared it on digital has to be transferred on the patient mouth. And then one you start working on it, patient, you first, and then the patient should approve the final outcome. Because remember, the teeth, the smile is dynamic. There are soft tissues, the upper lip and the lower lip, and all the muscles which are pulling it up. So it is more important how the patient looks when the patient is smiling, how the teeth are visible, how is the looking final outcome. So always give it a test drive, and if you are using digital, then follow those protocol. But I would also take this advantage of telling you here that using the analog, using the old good wax up done by a good laboratory ceramist technician, that is more important, will be still giving you the more predictable result, because everything is in your hand. You can slice it, you can trim it, you can add it, and you can see there and there itself. So that is
Most importantly,
absolutely
even
perfect.
we can do it ourselves. Take a lacquer
Absolutely,
mascara and just do it.
absolutely, absolutely right, absolutely right.
So the next one is, why is golden proportion applied for smile designing? And can we still do a good smile without it?
No, the answer is no. See, there is a small variation is available. So when we say golden proportion, please don't take it like it has to be exactly 66%. No, it can be between 60 to 70%. It is fine. But there has to be a proportion, because otherwise, I mean, in a layman's language, when they look at it, they will not understand what you have done. But what they say, doctor, this is not looking good. Now you may spend whole life, whole day spending arguing with the patient, see if it is good, color is matching, everything. This is not looking good. They are not able to express it. And some people may say that okay, looking too short, too small. So it is the proportion which gives you the final aesthetic. In life, whenever you see any monument, whenever, I mean, why do we love Taj Mahal? Why it is called beauty perfect? Because it follows a proportion. And all these proportions are been used even in nature. Even in nature they follow that, so we should not do disregard it.
We can just go, like you rightly said, a little bit in the range. So they are there to help us guide, give us some clue, kind of a. But
Sure.
yeah, we cannot really just ignore them and move.
Yeah.
Right. So the next question that we have is case selection and what factors to consider. So I think the delegate here wants to ask about the smile design factors or principles, maybe. And can you please guide us about the case selection for composite versus porcelain veneers here? Maybe that's the question that he wants
Yeah,
to
good
ask.
good question, Dr. Usha. So basically, see, I put it like this: composite is more forgiving you. You can play with it. You made a mistake, you can remove it, you can correct it, and you can do it. But it has got a limitation. The limitation is it cannot be extended. I mean, I call it cantilever. So you cannot make it, from where your tooth is ending, and from there you can only extend it to a millimeter or millimeter and a half. Beyond more than 1 millimeter, the cantilever part with the stresses coming in are likely to chip off or break. So, especially if you're talking about in case of diastema cases, I'm comfortable with 2 to 3 space closing with the composite. But if it is a 4 then I would definitely move towards the ceramic laminate. When it comes to the tooth structure, now if I have got a nice tooth structure where there is just a little bit addition has to be done, a small addition has to be done, then I'm okay with the composite. But I have to do a lot of reduction. I'm going to change the stump shade is going to get more and more darker. I need to block that light. Then my ceramic will be better. Because in terms of blocking the light and giving the translucency, ceramic scores over the composite. Because composite, each layer, the opaque composite has to be 0.5 and then each layer will land up becoming 1.5. The ceramic can be done in 1 to 1.25 so, and better translucency. Of course, long lasting effect, ceramic any day scores over the composite. So use your own judgment. and find out what is best for the patient for the given clinical situation.
Yeah. Also, I feel, sir, here the clinical skill of the doctor matters a lot.
Sure.
I feel if you are one if one is very talented and skilled enough to do a composite, do it. Otherwise, instead of giving a bad composite, maybe you can think about giving a good ceramic in that situation.
Absolutely, any day. That's always better.
Yeah. So the next one is, what's your method or approach for selecting a shade for composite veneer?
Okay. So I have, I mean, my journey started with a composite. I mean, I when I look back, it looks like historical. But the first ever lecture of composite in India was held at Taj Mahal Hotel, and this was in 1984, and I was just there, lucky. And from there, I've seen the whole evolution of composite. And the biggest challenge we have always faced was the shade. So earlier we would take multiple company composites and still layer and apply, which is basically how the multi-layering came into effect. But over a period of time, I found out that yes, there is a shade variation between even there is a color variation. I call it color variation between the same shade. So it is better that you take the composite directly and apply a small increment on the tooth where you want to replace it. Cure it, no etching, no bonding. Cure it and see for yourself whether it is blending. So I have developed a technique called color palette technique, in which where I take a small increment of different area and different opacity and different translucency, and create a palette to check whether it is which color of the composite and which shade and which company is blending there, and then one use it with that.
That's a very nice tip that we got from you, sir. So the next question also kind of relates to this, that different brands have different shades of the same composite. Example, A2 Dentine from 3M and Tokuyama are totally different.
True.
So how would you choose in that situation for anterior restorations?
Yeah, so that's what I said. This was revelation. I mean, yeah, I have just explained the same way technique, and this was confirmed with the when I was in Germany 15 years back, and I had literally fought with the research scientist there that how come your shade is different than the other, and then he explained to me, then he explained to me, sir, the pigment which is used to give the colors for the composites are different, and that is a part of the trade secret.
Yes,
So each
they will
company will
not.
follow the different. So the one way which we have got in our hand is to literally try it out and see that. But of course, what is happening is with the nano filled composites, that range has reducing, and I can see that nanofill composite, that because there was a huge range of color dissimilarity. With nanofill, it is reducing now. It is little bit lesser range, so it's better for us.
Yes, that's very nice. So the next is how to restore a smile in a patient when there is space of 4 to 5 millimeters between two central incisors.
Yeah, I said in my presentation also that up to 3 millimeter, 2 to 3 millimeter composites. Up to 4 millimeter will be porcelain laminate. Beyond 4 millimeter, please check the occlusion, because you cannot add 2.5 in each. Then it will go with the porcelain crown. And you did not go for PFM crown. You can go for full ceramic crown. So that is absolutely okay. And they will give you the good result. In fact, some cases I've done that. It was such a big spaces that we did a more combination. That means some teeth were put up a full ceramic crown, some teeth were put as porcelain laminate. The laminate, porcelain laminate, and some were porcelain crown, and together. But how did I decide it? I just I don't do all this ceramic work for myself, right? So I have to involve my technician. So what I do, I take the pictures, I take the models, and one copy of the model I keep it with me pre-op, and then I send it to my technician. And then over the phone, over the picture we discuss, he does the mock-up for me, send it back to me, and I make corrections, send it back to him, and then once we finalize it, that's how we come to know that okay, this would be the proper, the shampoo, the margin, the depth, the thickness, what is the color going to be coming, and then you use the material. Always take there is always a saying that the in the ceramist is your wife or your spouse without being in the clinic. So
With
ceramist
whom
has
you can't even fight.
you can't even fight. You have to go with them.
You have to have good
Take care of
relations.
them. And most of the time, their opinion is right.
That is true. So the next two questions I think you have already covered in your presentation, which is how to convince patients for smile designing, and is there any particular age group for smile designing?
Earlier, we used to have, it was thought of okay, young people will go for smile design. People who are only about to get married will go. Not anymore. Personally, in my practice, I have treated one case I've done for 55-year-old gentleman.
I've done one for 65-year-old lady.
And the reason is all this life I was having the gap. Now I have luxury of doing it. Of course,
Abhi
the
apne
wedding,
time.
abhi free hai. But of course, one of the main reason is also now the wedding or the celebration and the smile which you want to show. So that is one of the reason. Age is
As long
not a
as
bar.
the teeth are healthy, there is no age limit for any such procedure.
But on the lower limit, I take a caution. I don't do any major smile design work till 21, 22, because by the time the teeth are developing, the things are there. So I may do some composites, but not the porcelain work. So I may
Any
add a
kind of
composite.
reduction, you mean?
Yeah,
You will
yeah.
not
Any
do.
reduction I would like to avoid.
That's nice. So we are done with the questions. So that for the registered participants. Rajiv
Okay.
sir, can you please go ahead with
Yeah,
the Q&A?
that was an amazing question and answer session, and all I could see was sir has been there for last 4 decades, and he has seen composites evolve right in front of his eyes, and his practice has evolved. The materials have evolved rather with his practice. So
Yes.
that was amazing listening to your answers and learning so much from it. And we have a few questions here from the live audience. The first one is how to really reduce sensitivity after composite only restoration. To avoid this, I personally prefer GIC based sandwich technique. But what are the other options?
Dr. Dhar, the option is to use self-edge bonding system, which will take care of sensitivity. So you can use self-edge or you can use universal bonding system. Sensitivity arises primarily because of your improper bonding, etching, bonding, and curing. Also give attention to the cure. So you
So the
can
curing lights.
curing lights. Yeah. So what lights you're using, how much is the depth of cure, is it properly done? So please give attention to that, and this can be taken care of. Sandwich technique was the old technique. The biggest problem which we face sandwich technique, it is still good. I'm not saying it is bad, but the color. If you make the thickness of your glass ionomer more, then the color will see through. And the bond strength between bonding a composite directly to the tooth was vis-a-vis through the glass ionomer is different. With the tooth, it is much more stronger bond. So prefer to use, you can use self-edge technique. It will solve the problem.
This question came very early in the lecture when you are showing some of the anterior teeth cases. What are the chances of black triangle? Maybe he wants to know how to avoid, how to minimize black triangle.
Black triangle. Okay, I think Dr. Rajiv will be the best person to tell as a periodontist because the whole research shows that it was the periodontist who just brought to the notice that if the distance between the crest of the bone and the contact point is within 5 millimeter, papilla will be present, usually present. So give attention to that, indirect or indirect, and that is really the key, that keep the distance So 2 millimeter, you can keep it out. 2 to 2.5 millimeter, we say from the bone, because I'm not going to do the bone sounding all the time. But beyond that, if you keep it within 2 millimeter from your margin, your contact point, you will never have a black triangle. Papilla will grow there.
Amazing. Uh, in case of tongue thrust habit, to 50-year-old who comes for smile designing, how to go about it?
Break the habit first. or or I mean, without you committing anything major, because see, the with the thrust, the force is so much. We are not knowing how much is the tongue thrust and how much is the area keep fanning out. You may do your you may do your laminates or crown, whatever you're doing it. Now, if you're doing a laminate here, and this is an interesting study which I've seen some time back, that you can do a laminate and this came for some orthodontic treatment where they in order to relapse, what this person has done is after putting the laminate, there was a chance of tongue thrust or teeth coming out, to put a lingual retainer. So he just bonded from canine to canine lingual retainer as if he's doing orthodontic. So that makes sense. But here, this is a disclaimer. I'm not advocating this, but you can try it out. But ideal would be yes, stop the habit.
Okay, one more question. Dr. Suhasini has asked how to manage occlusion for veneers in deep bite or heavy bite cases so as to ensure they don't fail later.
The best way to go about is to take your, I mean, if you feel though those are the big bite cases or there could be a occlusal issue, take rubber base impression, do Facebook transfer. It is worth it. And take all the movements, envelope of function, protrusive, lateral expressions, and all the movements and check where it is coming in the hitting first. And then only you proceed. It is not it's not a contraindication, but yes, it requires more attention. Because in most of the time I found out that if it is a very deep bite, there is something which is at the back. One molar, one cusp is just coming, is obstructing. So we forget that and we blame the teeth. So take extra care, and Facebook mounting is a must.
Okay. What is the economical matrix system for class 3 cavities and preferable brush for composite blending?
Okay, so matrix for class 3, you can use a dead soft metal. Now 0.5 mm, 0.05 mm, and 0.025 mm. They are available. So with thin saw matrix, you can use them and do your restoration. They are more thinner than the regular mylar strip you get. Regular mylar strips are more thicker than the jet soft metal. One can use that. Brush, you can use Indian brushes. Don't go for the fancy brushes. I think Faber-Castell, Camlin, they've got good brushes. But remember, movement, as we say with the toothbrush, the bristles bend, throw it off. Here also some bristles out, throw it off. And they're not so much expensive. But never, ever use your regular bonding, dip it in the brush. That is bad. You have to use if you're going to use the the fourth generation resin only should be used as a wetting agent so that the brush does not stick to the composite.
Okay. Can we use silver diamond fluoride for reducing sensitivity?
Not required.
Okay. KY jelly O2 inhibition layer placed after composite restoration or after finishing and polishing?
Okay. So what happens is when you're curing the composite, the topmost layer is always oxygen inhibited layer. It's a soft layer, not completely cured. Earlier, when we were using hybrid or we were using microfilm, we were not too sure because the polishing system was not too perfect. So we used to wrap the mylar strip along with that and leave it as a final finish. In those cases, Deox, KY jelly, or another thing materials have been used earlier. Today, when I'm using nanofilm, and the and if I'm going to be, I prefer to use my finishing kit, the disc or the spirals, to remove the topmost layer. Those are in terms of micron, and that gives me more predictable outcome. Predictable outcome. It's better so that I can finish the last layer so that my uncured composite is removed. So KY jelly and other stuffs are not required anymore if you're removing the topmost layer in finishing polish.
Okay. Which composite brand would you suggest for anterior composite restoration?
I have been so far avoided recommending any
Yes.
particular brand. I will use that same. All brands are good. I always say, please follow the science. And my just give you one tip, and that is ask for the literature of the products. What is it made? What is the filler particle size? What are the clinical studies? What are the microscopic picture studies? Yourself. And the last thing which I always say, and this is possible today, tell the companies you have shortlisted two or three of them. Okay, so either you can buy small syringes or tell the company if you're going to place a big order that I want to use your composite for just one case and use it only for one case. Be religious. I mean, very, very fair. I'll one filling, I want to use it, your material, they will give you that material for one case, one day, and see for yourself. But first science, then your clinical skills. Needless to say, needless to say, there are finest composites. I'm not going to name them. The finest composites which get misused because we are not using them properly followed. Because there is a protocol to follow with each product. One must learn this in proper hands-on workshops, which is very essential. Because all composites are not the same. We should use them properly.
Okay. What is the role of glycerine?
Uh, I would say on the composite, no, but on the lips you can apply so that they don't get dry. No, glycerin is not required.
In case of bruxism and attrition and midline diastema, how to go about?
Hmm. Bruxism and attrition. Okay, so bruxism and attrition nothing to do with the midline. It's going to wear the whole tooth enamel uniformly. Again, I would like to hear the check your occlusion before you're going to do it. So same protocol, rubber base impression, Facebook articulating, and then check each and every step. Once you're satisfied, you can proceed. In case of a doubt, if it's a small case, a personal advice you first try with composite. First try with composite, and then see how is the result. If it is lasting there and it is good, that means you are got the proper shape and all. Then later on you can convert into ceramic or leave it like that. That's okay.
Okay. Usha, can you read this?
Which one, sir?
The question that I have put on the screen.
Brand for
Brand
nano hybrid composite
nano
3M.
hybrid composite.
Nano hybrid
350 is
composite.
nano
Yeah.
composite or
Z-
micro hybrid?
Yeah. Okay.
So basically,
So
on
yeah. So I'll give you the. So it is basically Z350XT. You're talking about 3M, right? So Z350XT is a pure nanofill composite with 20 nanometer filler particle, uniform filler particle thickness. It has got a cluster, which is nothing but loosely arranged nanofill composites. But the dimension of each particle is 20 nanometer. It's a pure nanofill. Z250 of 3M earlier was nano hybrid. So today that is not used much. Z350, which is pure nanofill composites.
Okay. So that brings us to the end of the session. I think we have completed all the questions sent before as well as the live questions. And there was one question that had come very early in the lecture, which I had kept for the end. Last question: where we can get minimal invasive training course from you? Let us know. I think Sir had put the slide. He had also shown the QR code. And since this is a very early part of the lecture, you asked this at 9:50 p.m. And anyway, sir showed the slide much later. You must have come across the slide. He had also shown the QR code. Of course, you can always go back to the YouTube video that will be putting a link of tomorrow, the recorded session, and you can again visit the same slide. So thank you, Dr. Pankaj Maheshwari sir, for taking out your valuable time and sharing your entire experience in such a short, the highly dense session. You covered as much as possible and you answered all the questions. I'm so thankful to you, very grateful for spending time with us. And I also thank Dr. Usha Dadlani, one more very busy practitioner, for taking time out and adding so
It
much
was
value
my
to the
pleasure.
session.
With
And with that, we'll bring this session to
Thank
an
you.
end.
Thank you. I would like to personally thank Dr. Usha and specifically Dr. Rajiv for putting all this together. I know it's a Herculean task to get so many things organized in meticulous detail for perfection. Make sure everything is goes in time. Has been really remarkable. Thank you, Dr. Rajiv, and thank ICPA for organizing these programs continuous basis. So they're really very helpful to us. Thank you.
So thank you everybody. Thank you to all the audience for joining in and making this session very, very interactive and successful. With this, we'll end the show. Thank you once again and a very good night.